Good afternoon, everyone. I'll just skip to the case. This is a 13-year-old child that presented in the outpatient department. He was referred to us for what we can see here as a gait problem and a left-sided thoracic hump. He was diagnosed with a dorsal spine X-ray having a left-sided thoracic scoliosis, and we can see a clear hip flexion. He's not able to completely extend the knees while he walks. So we got a full spine X-ray, and this is the picture that we found. We can see the classic inverted Napoleon hat, very high grade spondyloptosis L5S1 lytic type, completely unbalanced spine and an unbalanced pelvis. Further evaluation, symptomatically the patient had no problems. There was no radicular pain, there was not much of a back pain. He just presented with a gait problem, like not normal looking gait. This is the MRI and the CT scans that we got. Not much of a compression, a completely degenerated L5S1 disc, sacral doming and a dysplastic S1. So challenges that we had, we decided surgery because the child's spine is more mobile. We would not want to wait for the child to grow old and the deformity to become rigid, so the reduction also becomes a problem. So of course, the patient being a syndromic child, there are nutrition issues. Do we need IONM, the approach? I think all the points are well covered by my previous speaker, Dr. Rohit Thakur sir. The main problem here was the dysplastic pedicles at L4 and L5, which are our main anchors for the reduction of the spondyloptosis. But because of navigation, we were able to put in, so the tap here that we are seeing is a cervical pedicle screw tap of 2.7 mm, which still looks bigger in the axial cuts of the pedicles. We were able to have good purchase. We also decided to put the S2 AI screws, and the video shows gradual distraction and reduction of the listhesis. From grade 5, we could get it to grade 2 to 3, but of course bilateral facetal release, disc release, and an interbody fusion for better fusion rates. And this is our final result where we could align the L5 over S1, robust fixation, and of course autologous grafting for interbody as well as posterolateral fusion. And you can see the spine is now well balanced, a good lordosis. The vertical sacrum has also become normal. We did do a literature search. There are quite a few recorded cases of spondyloptosis in adult degen patients, but in neurofibromatosis we could find only 5 case reports, out of which 3 are of the lumbar spine at L5S1 and 2 are of the thoracic spine. All of them usually have the same problem, very thin dysplastic pedicles and dural ectasia, which make anchorage a problem, how to put the implants, and because all on the implant purchase. If any of the screw pulls out during reduction, then we are in soup, and the only salvage left then is an in situ fixation.